I'm Hyojung Lee from Ewha Women's University Mokdong Hospital. The title of this study is Effect of Microwave Ablation Power and Antenna Approach on Tumor Seeding, an ex vivo subcapsular tumor model study. Extrahepatic tumor seeding is a rare but significant complication related to the thermal ablation, and the subcapsular tumor location is a well-known risk factor. Low power radiofrequency (RF) ablation has been reported to delay stem popping, thus help to prevent tumor dissemination compared to the high power protocol. Previously, our research group revealed that adopting a low power protocol and a parallel approach to the hepatic capsule effectively reduced the risk of tumor seeding. However, no previous studies have investigated how energy power and antenna access direction affect seeding incidence after microwave ablation of subcapsular tumors. Therefore, this study aimed to investigate the effect of microwave power and antenna access method on tumor seeding and ablation zone size using an ex vivo subcapsular tumor mimic model. 4 bovine livers were obtained from a slaughterhouse, and the livers were cut into 41 blocks, each measuring 10 by 10 by 5 centimeter, with care taken to avoid large vessels. All liver blocks had a hepatic capsule on one side. We created our tumor models used a solution consisted of agarose, cellulose, glycerol, and iodine contrast medium. To ensure a consistently spherical-shaped tumor, we designed a balloon catheter. The 9-prince dilator was cut, and the medical condom was tightly tied 1 centimeter away from the distal tip, and the tight condom tip inflated like a balloon when the solution was injected. Under ultrasound guidance, the catheter was inserted into the liver block and positioned 5 mm below the hepatic capsule. Then the mixture was injected through the dilator and the diameter of the hyperechoic tumor mimic model was measured. CT scan was acquired for all tumor mimic models before and after ablation. Ablation were performed at 75 watt for 4 minutes and 100 watt for 3 minutes. The energy delivered during the ablation was same in both groups. The time at which the first popping sound occurred during the procedure was recorded. The antenna approach was assessed in 2 directions, parallel and perpendicular. For parallel access, the antenna was introduced parallel to the hepatic capsule and positioned 5 mm beneath the capsule through the center of the tumor mimic model. For the perpendicular access, the antenna was inserted toward the capsule. Capsule is here, and its tip was placed 5 mm away from the capsule. Parallel access with the low power protocol was applied to 11 tumor mimic models, parallel with high power to 10 models, perpendicular with low power to 10 models, and perpendicular with high power to 10 models. The presence of high-density contrast material on hepatic surface on post-ablation CT compared to the pre-ablation image confirmed the presence of contrast leakage. Finally, the liver blocks were sectioned along the antenna insertion tract. The size of ablation zone was measured in 2 dimensions, the longest diameter and its perpendicular diameter. For group comparisons, species zigzag test and the man-Whitney U test was used. Two-way ANOVA and logistic regression were used to determine whether there was an interaction between energy power and approach method. So let's see the result. This table shows the comparison of the ablation powers. 5 cases of the 5 cases of contrast leaks were observed in the low power group and 17 in the high power group. The popping sound timing was significantly delayed in the low power compared to the high power groups. The ablation zone size of the specimens was not significantly different between two groups. In comparison of the antenna approach methods, 10 cases of contrast leaks were observed using parallel approach and 12 using the perpendicular approach. The popping sound timing and the ablation zone size were not significantly different between the two approaches. There was no significant interaction between the ablation power and antenna approach method in terms of the popping sound timing, number of contrast leaks, and ablation zone size. This table presents the result based on the energy power for each approach. Contrast leaks were observed less in the low power protocol compared to the high power, regardless of the antenna approach. The popping sound timing was significantly delayed in low power group, regardless of the access method. In this study, we present the results obtained from the ex vivo subcapsular body tumor mimic models. Fewer contrast leaks were observed in the low power group than in the high power group in both the parallel and perpendicular approaches. Additionally, the low power group exhibited a significantly delayed popping sound compared with the high power group. Notably, the size of the ablation zone did not differ significantly between the groups. We compared the current results with those of the previous study using RF ablation. While the advantages of low-power RF ablation were evident only in the parallel approach in previous study, the current study confirms these benefits irrespective of the approach direction in microwave ablation. These differences may be attributed to the distinct locations of energy concentration in the two modalities. In RF ablation, energy is primarily concentrated at the distal tip of the electrode, with the tip facing the hepatic capsule in perpendicular approach. This concentrated area exhibits relatively high temperature and pressure, making the capsule more susceptible to disruption, even with low energy RF ablation. In contrast, in microwave ablation, the energy is focused on the distal two-thirds of the active tip of the antenna, situated farther from the hepatic capsule than in RF ablation. Therefore, the capsule is less susceptible to rupture during microwave ablation, providing an advantage for the low-power protocol, as seen in the parallel approach. A subcapsular tumor in the anterior segment allows parallel access, avoiding direct puncture. But achieving parallel access in the posterior segment, especially segment 7, is very challenging. Therefore, a perpendicular access is inevitable. Low-power microwave ablation is recommended over radiofrequency ablation to reduce risk of seeding. This study had several limitations. First, the study was confined to an ex vivo setting, therefore it cannot represent in vivo physiology. Second, the gelatin-like tumor mimic models used in the study dissolved in liquid at high temperature during ablation, making them more susceptible to leakage than in their solid state. Finally, this study did not account for additional factors influencing the risk of tumor seeding. In conclusion, low-power microwave ablation may be superior to a high-power protocol for reduce the risk of seeding in subcapsular tumors, regardless of the antenna access method. Thank you for your interest in my research. If you have any questions or comments, please feel free to contact me. Thank you.